Well, the open payment system was established by the Physician Payment Sunshine Act several years ago, which allows all companies established in the United States that produce or purchase drugs or devices that are reimbursable by a government-run healthcare program such as Medicare. They need to basically announce all their payments to dermatologists. So once a year, the government gives the companies a particular time frame to establish these payments. They need to go online to a website and list the physician, the amount, and the type of payment that they are giving out.
That was Dr. Alan Shih. In this episode of Dermatology Weekly, Dr. Shih joins Dr. Vincent DeLeo to discuss how accurately dermatologists, who are presenters at major medical meetings, disclose industry conflicts. This is Dermatology Weekly, the official podcast of MD Edge Dermatology. I'm the voice of MD Edge Podcasts, Nick Andrews. Stay tuned later for Peer-to-Peer with Dr. Vincent DeLeo, where he'll be joined by Dr. Alan Shih. Don't forget, if you have feedback or comments, you can email us at podcasts@mdedge.com, or you can interact with us on Twitter. For the news portion of this episode, we're addressing an essential question. Is private equity in dermatology practices a savior or a death sentence? In 2019, 184 dermatology practices that comprised 381 clinics were owned by just 17 different private equity groups. And private acquisitions have been climbing aggressively for years. There were 5 acquisitions in 2012, but there were 59 by 2017. These data come from a study published in JAMA Dermatology back in 2019. The influx of private money has been hotly debated for years. In fact, it was a debate at the 2019 annual meeting of the American Academy of Dermatology and was scheduled again as a debate at AAD 2020, which was of course canceled due to COVID-19. There are 2 basic questions surrounding this practice of new private money that are at the root of the debate. First, why is this happening? And secondly, is it good or bad? So first, why is private money interested? And why are dermatologists selling?
Did you ever see that movie, The Big Short?
That's Alicia Alt. She's a journalist who's been covering health policy, science, and medicine for about 30 years. She wrote this story for MD Edge Dermatology. Alicia said the complexity of the financial side of this reminded her of The Big Short, which was an Adam McKay movie about how some investors saw the 2008 financial crisis coming and bet against the market.
Initially, this is real simple, where the private investor starts out, buys a bunch of dermatology practices, bundles them together, and now they brand it as either under the name of the original practice or they create a new brand. And now they've got 10 or 20 or 50, and they can have their efficiencies and the economies of scale. They don't really want to be in the healthcare business. They're in business to make money.
And because investors buying these practices are private, they don't answer to investors. And they're not subject to the same open book policies that regulate, say, the New York Stock Exchange. There is essentially no public oversight and no accountability. To make practices more profitable, private equity could, and in some occasions does, install new management to push certain pathways. One of the new techniques is hiring more mid-level clinicians, specifically more nurse practitioners and physician assistants. Why is that? Simple. They perform more procedures. In a 2018 study published in JAMA Dermatology, researchers reported that on average, PAs needed to perform 3.9 biopsies to diagnose one skin cancer. That's almost 20% more biopsies per skin cancer diagnosis than dermatologists. And when researchers looked at biopsies per diagnosis for melanoma, the difference was even bigger. Dermatologists performed about 25 per melanoma diagnosis, while PAs performed more than 39. Dr. Brett Calderon is former president of the American Academy of Dermatology. Dr. Calderon has been critical of the influx of private investors. He's gone as far as to say that the influx may be, quote, the undoing of our specialty, unquote. Dr. Calderon believes that investor owners push for more procedures that pay well. Procedures like freezing actinic keratoses, Mohs surgery, and yes, biopsies. Indeed, according to Dr. Calderon, the number of skin biopsies has nearly doubled in the last decade, and the ongoing skin cancer epidemic would only account for about half of those. The ultimate loser in all of this is the patient. Not only are they not getting the highest quality of care, but they are undergoing unnecessary procedures, he said. But if that's the case, and patients really are experiencing worse care, why would a dermatologist or any private clinician sell their practice?
I think it's a pretty good exit strategy for somebody who knows they're going to retire in the next 5 years or 2 years or something. I think that's who it's really attractive to. And they see it as a payday because the numbers sound really good in terms of the buyout. But what happens is they almost finance their own buyout because they don't typically get it in a lump sum. They're asked to stay on, they're contractually obligated to stay on 2 years or 5 years. I think 5 is generally the norm. And they're actually taking a reduction in salary during that period because they're going to get this sum at the end, but it's a way for them to transition the practice without too much hassle.
As you mentioned before, the issue is hotly contested. Dr. Leslie Bauman is a mother of 2 who had a tough time keeping up with the business side of running a medical practice, so she decided to sell. First, she sought interest from her clinical business partners at the practice. After her partners showed no interest, she searched for a local investor to buy the practice. And after she got nowhere with that, she looked into private equity. In October of 2019, she sold to a group she said she had a long track record of successfully running practices, and that doctors who worked for the practice owned by the group were happy. She was satisfied with their research. She agreed to stay on at the clinic for 5 years under a non-compete clause that was reasonable. She said that she enjoys the freedom she has to use telemedicine, to consult with an expert on pigmented lesions, quick referrals to a Mohs surgeon, and being able to train residents. She also cites paid personal time off as a new perk for her. In all, less responsibility with the same or even greater job satisfaction. However, when she shared the news online in a closed Facebook group of board-certified dermatologists, she was attacked. Nearly 200 comments on her post, about half of which were mean-spirited. This debate will soon crawl into other specialties, if it isn't there already.
Dermatologists who are wondering about this should definitely talk to colleagues who might have sold out to private equity. They need to really educate themselves if they're being approached, because I heard a lot of bad stories from people who kind of felt like they've been burned. You know, they've gotten a real hustle. And also they could talk to specialists in other fields because it's not just dermatology. This is happening in every medical specialty.
You can read this story in its entirety with links to journal articles and further references by clicking the link in the podcast notes. The news portion of Dermatology Weekly is produced by Elizabeth Meshkati, Kathy Skarbeck, and Mary Ellen Schneider, as well as Terry Rudd. Dr. Calderon and Dr. Bauman are both on the editorial board for Dermatology News at MD Edge. Special thanks to Alicia Alt for joining us this week. Derm Weekly will be right back with Peer to Peer after this. Welcome back to episode 62 of Dermatology Weekly. I am Nick Andrews. It's time now for Peer to Peer. Please welcome the host of Peer to Peer, Dr. Vincent DeLeo.
Today we're talking to Dr. Alan Shih about how dermatologists disclose industry conflicts of interest. Dr. Shih is from Boston University in Massachusetts. Thank you so much for joining us today, Dr. Shih.
No worries. Thanks so much for having me.
So let's get started. Can you explain how the Open Payments, or OP, database works in collecting industry-supported physician interaction?
Sure. Well, the Open Payment System was established by the Physician Payment Sunshine Act several years ago, which allows all companies established in the United States that produce or purchase drugs or devices that are reimbursable by government-run healthcare programs such as Medicare. They need to basically announce all their payments to dermatologists. So once a year, the government gives the companies a particular time frame to establish these payments, need to go online to a website and list the physician, the amount, and the type of payment that they are giving out.
So what did you seek to study in your retrospective cohort?
I thought to study what was the difference between the amount of disclosures by dermatologists themselves at a large AAD meeting, which is held every year, versus what the companies report on their end.
And so you were comparing what dermatologists reported to the AAD, which they must do when they give a presentation, right?
Exactly. So when all the speakers at the AAD agreed to be a part of the program, they must disclose a full page about all the companies, the type of interactions, and sort of detail that. That is a publicly available disclosure list that's available in the meeting program.
And so you were comparing the OP database to that database, correct?
Yes, exactly. We were comparing the open payments to the AAD meeting program disclosure.
So what did you find in terms of under-disclosures or over-disclosures between those two databases?
So we were going into the study with an open mind, and with our team, we actually were able to find that the majority of dermatologists were disclosing completely and comprehensively all their interactions with industry. But there was about 30% or so which had this discrepancy between these two databases.
What did you find was the most commonly reported relationship with industry among the dermatologists?
So among the dermatologists, the most commonly reported relationships were definitely being an investigator, then a consultant, and then part of the advisory board. And specifically among these three roles, the form of payments that dermatologists reported were number 1 and number 2, honoraria and grants and research funding.
So did you find some forms of payment that weren't recorded in the AAD meeting program?
Yes. That's a great question, because when you do any study linking together two databases, there inherently are some differences in the way these databases are structured. And in the AAD, you didn't have disclosures for certain items such as travel and lodging, which do show up in the open payments database.
So overall, how did the disclosures between the OP and the AAD meeting program compare?
So overall, the disclosures between open payments and AAD compared reasonably well. We did end up excluding a lot of the food, beverage, travel, and lodging expenses because they were large in number, but they actually were very small in terms of the total amount of dollars received. And using that analysis, we found that 66% were accurately and fully disclosed by dermatologists.
That's interesting that there wasn't a lot of underreporting to the AAD in your study. Now, this was for dermatologists. How does this compare with other specialists?
Right. So given the fact that open payment started in the late 2010s, we've actually seen a lot of research coming out in all different specialties regarding the comparison of open payments and various academy disclosures. So looking at other specialties, we were able to find that we had a very similar rate in dermatology. So if we looked at, for example, an annual gynecology scientific meeting by Thompson et al., they listed about 62% of physicians had interactions on the open payments database that were fully disclosed. Another from orthopedics showed that the rate was about 70% or so. And lastly, there was a published article from ophthalmology, and they quoted an under-disclosure rate of about 35%. So it looks like we are sort of in line with what other specialists are seeing from other specialties. And I guess this leads to the next question of what is the meaning of the differences?
Exactly.
So, we're thinking about what could lead to all these different changes. Obviously, we're looking at a database that was just funded by the government. And so it has all its kinks to iron out at the early stage of the game. And then we also have the disclosures from the academies, which have different characteristics. And so I think that is one, the differences in the reporting of categories. Secondly, there could be some differences in industry reporting inaccuracies. For example, there's no audit on every single interaction that's reported by industry. So to whoever's listening, if you have a payment that you see, you could check it online to make sure it's not something that was entered under your name erroneously, which has happened before. And lastly, sometimes there is a lack of relationship between the industry payment and the presentation topic. So, for example, a dermatologist who goes to AAD to speak about psoriasis may not feel the need, if they aren't familiar with this disclosure, to disclose items that may be related to a laser, for example, or to something that is out of what they think is the scope of their interaction given their talk at that point in time.
That's very interesting. Can I ask you a question about the public's viewing of the open payments database? Is that something that our patients are looking at?
Yes, for sure. So one of the reasons that Congress decided to include open payments was to include the transparency and objectivity in our medical landscape today, so that patients and providers and the general public alike would be able to find if there were particular biases that physicians were having based on financial interactions that were yet to be revealed. And so you can go online to the Open Payments website, which is cms.gov/openpayments, and literally search up your own doctor or any of your colleagues that you would like. And the tool is pretty easy to use. It's similar to, I would say, the Google search function. And going on there, you can get a list by year, calendar year, of all the interactions and the type of payments that were received.
That's great information for our listeners to understand that actually their patients could be checking to see if there are any biases by the doctors that they're seeing. So that is quite interesting, I think. Tell me, what conclusions did you draw from these findings? How do you think dermatologists can do a better job of disclosing conflicts of interest with industry?
Dermatologists should be aware that these differences do exist between these databases, which some of it may be inherent to the database itself. But in the spirit of these databases being used to increase transparency in medicine, you can potentially have very, very negative public perceptions regarding the lack of transparency per se, if it's interpreted that way. And so given that, I think it's very important for dermatologists to continue to review industry-reported interactions listed on the online Open Payments database and to make sure it is as accurate as possible. And just to that effect, I can say that every year CMS gives all physicians a 45-day review period. And this period for the last calendar year of 2019 actually started on April 1st and will go until middle of May, so May 15th. And so during that time, if you could go online and just make sure that the companies are not erroneously listing you by any form of payment, you can be able to review that and submit a correction to the CMS.
Well, this has been a very interesting conversation today, Dr. Shih, and we would like to thank you for joining us. Do you have anything else you'd like to add?
Just one interesting development since the Open Payments is that first the Open Payments database was directed toward physicians. But more recently in 2018, there's actually been a change in that legislation. With the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients Community Act, which is a pretty long name, but it's a support act, it actually will start to include payments to other medical providers, not just MDs and DOs, including PAs, nurse practitioners, clinical nurse specialists, nurse anesthetists, and even midwives. And they've also added more categories as well. So I think what you're seeing is an increasing movement toward more transparency, not just at the provider medical level, but also at sort of all healthcare providers at all levels of care.
That is very interesting. So once again, we want to thank you for joining us. Have a safe and sane day.
And that concludes episode 61 of Derm Weekly. Derm Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show is produced by Melissa Sears and hosted by Dr. Vincent DeLeo. The guest in this episode was Dr. Alan Shih. The news portion of Derm Weekly is produced by MD Edge editor Elizabeth Meshkati. This episode's news was based on a story originally published at MD Edge by Alicia Alt. All MD Edge podcasts are produced by MD Edge and Medscape Editor-in-Chief, Dr. Ivan Oransky, and executive editors Kathy Skarbeck and Mary Ellen Schneider, as well as multimedia editor Terry Rudd. Derm Weekly is produced, edited, and engineered by Tyler Mundek. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.